I'm Gabriella DeLuca, a student physical therapist from Stony Brook University, and this is my in-service about spinal cord injury. There are many different ways to characterize and categorize spinal cord injuries. First, you can classify them based on their cause. You can have a traumatic spinal cord injury, which would be from some type of trauma, like a motor vehicle accident or a fall, or you can have a non-traumatic spinal cord injury, which could be from a circulatory or neurologic issue. You could also categorize them as complete or incomplete. A complete spinal cord injury has no sensory or motor functioning below the level of injury, except for a possible zone of partial preservation between the injury and S4 or S5. An incomplete spinal cord injury could have some distal sensory or motor functioning below the level of injury, and these patients would also have sacral sparing of S4 or S5. This is depicted on this graphic, which shows different ways to test for sacral sparing, looking for motor, which would be great toe flexion, or sensory functioning, which would be in the perianal and genital areas. Both of the complete and incomplete spinal cord injuries, though, would have an intact bulbocavernous reflex, which is showed, and this would appear after the initial period of spinal shock, which I'll talk about later. And lastly, depending on the level of injury, patients could be paraplegic or tetraplegic. The ASIA scale is also used to classify spinal cord injuries. You can be graded A through E based on the impairments shown from your injury. So a grade of A would be a complete spinal cord injury, and a grade of E would be normal, and all would fill out in between. So you would grade their motor functioning and their sensory function on the ASIA scale. And the way that you would grade motor is you would look at the highest level with an MMT score of 3, and it has to have a score of 5, which is normal, above. So that's a little bit confusing, but the highest level would obviously be referring to towards the cervical spine. And then sensory grading is a little bit more straightforward. That's just the highest level with normal sensory functioning. Depending on the level of injury, patients with spinal cord injury will present with different impairments and functional abilities. So on this slide, I'm going to be referring to the spinal nerve, and all of the spinal nerves exit below the corresponding vertebra, except for in the cervical spine. So it gets a little bit confusing, but try to bear with me. So if the injury is between spinal nerves C1 through C4, this patient will require a ventilator to breathe, and they usually will not be able to speak either. They'll also be quadriplegic. And then if the injury is to level C5 spinal nerve, they usually will have the ability to breathe, although it will be weak. And then a patient with C6, they gain some wrist control, so they may be able to drive an adaptive vehicle. And if the injury is to spinal nerve C8, they will have all of the control of their hands, so they will have the ability to grasp and grip things for ADLs. In the thoracic spine, an injury to T1 would show with normal hand and arm functioning, and then all of the rest of the thoracic spine deals with more trunk functioning. In the lumbar region, L1 and L2 injuries will affect the bowel and bladder functioning, and the rest of the lumbar functioning will affect the lower extremities. And lastly, in the sacral region, there is no full hip functioning if you have an injury to S1, and then S2 through S4 is the loss of perineal sensation and a little bit more bowel and bladder functioning as well. A common problem that patients with spinal cord injury will have is neurogenic bladder and bowel, and I divided this into two categories based on the level of injury. So if the injury is above the sacrum, they'll present differently with their bowel and bladder functioning compared to injuries below the sacrum. So in a suprasacral spinal cord injury, they will have intact bowel and bladder reflex functioning, but they will have lost sensation. I did a question mark because sometimes they do still have sensation, but they will not have voluntary control of their bowel and bladder, so this will make them incontinent. and this is known as overactive bladder and reflex bowel. The overactive bladder will require catheterization, and the reflex bowel will sometimes require stimulation of bowel, but usually this is just happening on a reflexive basis, and they just can't control their bowel. And then if the injury is to the sacral spinal cord, they'll have lost sensation, reflexive emptying, and voluntary control. So there will be no emptying of the bowel or bladder going on. This will lead to urinary and bowel retention. This is known as underactive bladder and flaccid bowel. And like the suprasacral spinal cord injuries, this will also require bladder catheterization, but unlike the reflex bowel, they have no bowel movements happening, so they will require a little bit more attention to their bowels to be doing manual stool removal. Immediately following a spinal cord injury, patients will experience spinal shock. This is the absence of motor, sensory, and reflex functioning below the level of injury. It lasts for about 3 months after the initial injury, and this also depends on the severity of the injury. It could also radiate slightly above the level. So they think that this is due to a loss of input from the rubrospinal, vestibulospinal, and reticulospinal tracts. This then disrupts the facilitation of gamma motor neurons that control muscle stretch reflexes and resting tone. During this period of time, patients usually experience hypotension, bradycardia, skin hyperemia, and neurogenic flaccid bowel and bladder. Eventually, spinal shock starts to diminish, and when patients begin to come out of this period of time, they will become hyperreflexive. Since their former source of facilitation from higher centers is lost, these reflex pathways compensate and increase their excitability and sprout to collateral dead areas, resulting in hyperreflexia. The first reflex to come back within 1 hour of the initial injury is the delayed plantar reflex. This reflex has the same stimulus as the Babinski sign, but the response is prolonged and also delayed. Then, within the same day of injury, other cutaneous reflexes will come back. This includes the bulbocavernous reflex that I spoke about earlier, as well as the cremasteric reflex. And then eventually, when the patient is no longer in spinal shock, they will lose the delayed plantar reflex, and they will instead have a positive Babinski sign. Then spasticity will begin months after the initial injury. This is a type of maladaptive neuroplasticity where the stretch reflex is more excitable, so patients will exhibit a velocity-dependent resistance to passive stretch. This means that the faster you range the limb, the more resistance to that motion you will feel, and it will have a sort of catch and release pattern throughout the range. For patients with spinal cord injury, this is very common in opposing muscle groups, as opposed to patients post-stroke, which will have spasticity in their upper extremity flexors and lower extremity extensors. And spasticity is worse with incomplete spinal cord lesions. Autonomic dysreflexia is a very common issue for patients with spinal cord injury above the level of T6. This is a way for the body below the level of injury to communicate, since there are no signals for sensation getting up to the higher brain centers. If there is a noxious stimuli below the level of injury, the body will protect itself by sending off a sympathetic nervous system reflex loop. The first response is vasoconstriction of the vasculature below the level of injury and throughout the body, and this will result in bradycardia, an increase in blood pressure, headache, diaphoresis, goosebumps, and visual disturbance. And this noxious stimuli should be found immediately so that this reflex loop can be shut down. This is the last slide of my presentation, so I just wanted to go over some general treatment precautions to keep in mind when treating patients with spinal cord injury, and this would obviously differ case to case. So first, if there was any damage or surgery to the spine itself, we remember no BLTs, which is bending, lifting, and twisting. So we would be teaching log rolling techniques in bed and making sure that when patients are sitting edge of bed, for example, they don't do any unilateral upper extremity extension and instead would be reaching back with both arms so that they're limiting the amount of twisting going on at the spine. Decubiti ulcers are also common in these patients because they may not be able to feel injuries to the skin below the level of injury and will not be adjusting their body weight in bed when they should be. So we want to monitor for these injuries and teach patients positioning or bed mobility and encourage frequent postural changes. Pneumonia is the leading cause of death in patients with spinal cord injury. So we want to make sure that we're encouraging as much physical activity, getting out of bed, sitting up, as they can tolerate in order to mobilize these secretions. These patients could be good candidates for deep breathing exercises as well, such as pursed lip breathing or incentive spirometry. And lastly, DVTs are another common issue, so we want to encourage passive range of motion exercises. We would also monitor for the symptoms of DVT, such as edema, warmth, and pain upon compression, so that this issue can be addressed immediately. Thanks for watching, everyone.